Ryan and his folks to have available if they want to look back at it.
Sure. Just hit record, so we're good to go.
Wonderful. Thank you. Well, again, thank you for being part of the Rise OK project. I'm Dr. Steve Crawford. I'm medical director of the Oklahoma Primary Healthcare Improvement Cooperative. You all well know this. This is something that Dan Duffy and I have been involved with since 2014 with the original H2O project, or Healthy Hearts. And this is a new project being funded through ARC that's to help with the essentially pain management in the elderly. We titled it Rise OK. We were trying to think of an acronym for this, and it's reducing the incidence of now I've forgotten, my brain just went on hold, but essentially the inappropriate use of opioids in the elderly, but using it in a safer mode than hopefully we have in the past. But why is it important? Pain is a very common problem in older adults, and it's challenging for many clinicians and what to do for this pain. Many times older adults have higher risk of poor outcomes, especially if they're taking combos of opiates and benzos, if they're depressed, if they do become cognitively impaired, or unfortunately, if they have some type of substance use disorder, particularly alcohol. Can often achieve their goals in life with goal-directed multimodal approach to pain rather than just thinking of opioids as the only choice. And our hope is to enhance the joy in practice for many clinicians and make it so it's not such a frustration in dealing with this issue that we've experienced over the last 5 to 10 years or more in practice, particularly with the advent of many of the restrictions that have come up with the new laws and those types of restrictions. Again, this is a joint program that we do with our Oklahoma Primary Healthcare Improvement Cooperative that's part of the Sciences Center. We make up this particular guide with a company called Alosa Health that's out of Boston that developed the whole idea of academic detailing. And so this is just one of our many different academic detailing guides we've designed. Missy, if she hasn't already, will provide a hard copy of this in a much nicer form than just a PowerPoint. But we'll also make this available to you all. Again, pain is common in older adults, and risky opioids are frequently the response. More than 30% of older adults in the US report chronic pain, and more than 2/3 report that it prevents them from engaging in activities they enjoy or did enjoy. And they're more commonly prescribed in older adults than any other age group. In 2019, 1 in 4 adults aged 65 and older received an opioid prescription, but it can cause serious problems, as you can see in the graphics that are on the right side of this page. And you all probably have experienced that in many of your patients that have chronic pain and that have used opioids now or in the past. So the first thing to note is, and we did get why this became such an issue is in the 80s and particularly the 90s, there was a big push to try to eliminate pain, try to decrease it as much as possible, to the point that there was theories that we could eliminate it if we just gave enough opioids. The problem is that even with acute pain problems, such as even tooth extractions or significant surgeries or musculoskeletal injuries, short-term pain conditions can typically resolve over time usually they'll resolve in no more than 30 days, but if you use opioids and you keep them going, it can certainly lead to continued chronic use. So the hope is to try to use non-drug approaches, NSAIDs or acetaminophen, other non-opioid drug options if available, and then only use opioids if required. And to look towards the whole purpose is to improve function, reduce suffering, and minimize the treatment-related risk associated with treatment of pain, acute pain particularly. If you're newly prescribing opioids for acute pain, prescribe a short course of immediate release at low doses, ideally 3 days or fewer. It's usually needed. Now, if they've had a major surgery, they may need more, but some patients can get by with a very few days of opioid therapy. Again, if they've been on or not been on non-opioid treatments, consider those. Obviously, checking the Oklahoma prescription monitoring and program is very important prior to prescribing to make sure that they, even inadvertently, many patients don't recognize some pain medications or that they got some from a dentist or ER doctor and they already have a supply and you don't need to give them more. The problem becomes each refill or additional week of opioid prescribed, as the little box at the top right, increases the risk of opioid misuse disorder by 20%. And if you have to prescribe opioids for acute pain in patients who are already on long-term opioids, what we call legacy patients, again, the hope is to use the lowest effective dose for an additional immediate release for the shortest time possible. And continue to emphasize the multimodal approaches. If they're on long-term opioids and if they haven't been previously prescribed naloxone, this is certainly a time to think about that, because adding more opioid on top of the chronic opioid increases that risk of an opioid overdose for a variety of reasons, and naloxone can be a lifesaver. And then if you have a patient that's receiving medicine for addiction treatment, such as Suboxone, and you're not already the prescriber of the Suboxone or other medication-assisted therapies, you need to coordinate that with that particular provider who's prescribing that. So those are important to do. And then if you're prescribing for chronic pain management, excuse me, need to clear my voice. If the pain lasts longer than 90 days of expected healing, then we're talking about chronic pain. And here it's really critical to focus on functional goals, optimizing additional non-drug and non-opioid drug treatment options. And if you do prescribe opioids, to certainly ensure the safety of the patient while you're prescribing it. Again, you need to look at what we call goal-oriented therapy. What are the goals that you and the patient have decided that they're searching for in using the pain medication, whatever pain medication you're using? And you're using their values and priorities and how to deal with this particular issue. And how do these goals guide your decisions about what medical interventions you do, whether it be opioids or non-opioids? And typical ways to explore this with patient is to ask them questions like, what do you do on a typical day? What things are you unable to do as a result of the pain you're having? What else would you be doing before the pain got so bad? Or what were you doing before the pain got so bad? What would you like to do that you can't do now if we were to help with that pain? And what activities give you purpose or joy in your life? Again, we try to think of the whole person, not just their medical issues, but they have obviously social interactions that they perform. They're obviously affected by how their brain reacts or their psychological makeup, which is made also affected by spiritual issues and obviously other medical issues that they may be dealing with. Assessing their mental health using screening tools for depression or anxiety, such as the PHQ-9 or GAD-7, can be quite helpful in helping you define and measure that and monitor that issue. In this particular slide, to make it fit, it's usually on top, both tables are on top of each other, but these are showing evidence for non-opioid chronic pain management options. And you all know the difference between the neuropathic and nociceptive pain types, and showing the different modalities that are available and where they work best. The green dots showing that there are better than control outcomes in good evidence-based studies. The yellow dots I think there's only one really yellow dot, and that's in mindfulness meditation for inconsistent benefit for nociceptive pain. And the white dots are not studied, that we couldn't find evidence necessarily for that medicine that or modality. Doesn't mean it may not work, but it just doesn't, there isn't strong evidence in that situation. Things to make sure of is that physical activity recommendations are appropriate almost in all patients. Acetaminophen should be thought of as a first-line option because of its safety in regards to GI bleeding and drug-drug interactions, and even drug disease interactions, even in people with chronic liver disease, if you keep it under 2 to 3 grams a day, particularly 2 grams a day in those that have chronic liver conditions. Topical options should certainly be thought of, including topical lidocaine and topical NSAIDs such as diclofenac gel. And when you use NSAIDs, oral NSAIDs, they should be used, if possible, for a short course due to their risk, cardiovascular and renal risk. Also with if you're having issues associated with GI, I'm certain most of you think about using a PPI in those situations to lessen the GI risk with that. This is an acronym that we used in our previous projects called Do No Harm that Dr. Dan Duffy actually came up with. And this helps us remind ourselves that if we're going to use opioids, ensure safer prescribings if they're used. So do assess pain, create a pain management plan, set a goal for improved function, not necessarily zeroing out pain, and do prescribe naloxone, particularly if there are certain indications for it. Don't prescribe an opioid without an assessment and plan. Don't try your best not to provide a sedating medication if you're using opioids. And our hope is no overdose deaths or suicides if you follow the guidelines. Under harm reduction, if by avoiding or tapering opioids, if you find they're ineffective, they have significant side effects, if they develop an opioid use disorder, or they develop or have significant health care or behavioral health problems. Agree in writing with the patient that there are risks of opioids, there are benefits, that they will use one prescriber or one prescriber group. Particularly, I know in a faculty practice, when people are busy, that you need to rely on your colleagues in that setting, that they use only one pharmacy, that they get no early refills, except in very, very rare situations, that they do come in for regular monitoring visits, that they know that they'll be requesting random urine drug testing, and that you all will be checking the PMP for particular issues, and that if for some reason they do have an event where they are not in your practice, but they have an event that creates a need for an acute opioid, that they contact your office at the earliest possible time to make you aware that they did get a prescription for an opioid. That if you're going to RX opioids, the lowest effective dose, you only use immediate release formulations. You try to use only 3 to 7 days for acute pain, and that you try your best to keep it under 50 MME morphine milliequivalents per day for chronic life limiting pain, and that we obviously monitor progress towards functional goals rather than eliminating pain. You monitor for misuse, you monitor for side effects, and for treating or referring if they do develop opioid use disorder. Again, if you're prescribing opioids for older adults, start low and go slow. Monitor particularly for the side effects such as constipation that unfortunately is very common in the older adult, but also those other side effects including nausea, sedation, and falls. That you personalize the plan to the patient's preferences based on their risk-benefit discussion. That opioids have a time-limited role to facilitate other treatment options, such as you've decided to send them to physical therapy or other forms of therapy, and that'll help get them there. And it's very helpful for the patient to have a pill organizer so that they don't accidentally overuse any of their medications, including opioids. And you work with if they have a caregiver, that the caregiver be involved in helping with that, particularly if they have a cognitive impairment. Again, we do, and Missy will go over the issue of safe disposal of unused or expired medications. We do have kits available that that we get through our Department of Mental Health contractor that's helped with our other projects. And we also have information on other safe disposal methods. So the best practices for patients who are already receiving long-term opioids, those that we call our legacy patients. Again, it's important to assess their functional goals, evaluate side effects, check the PMP. It is important in these patients to screen for opioid misuse and abuse using an SBIRT or an SBIRT-like tool. SBIRT, as most of you know, is screening, brief intervention, and referral for treatment. And screening, it started as a screening particularly for alcohol use disorder, but we broadened the term, and many have, for substance use and depression and such, and even tobacco use disorder, to use that particular tool and thinking to put it into a regular practice for most primary care clinicians. Again, our goal is to taper to the lowest effective dose the patient finds that meeting their goal and meeting safety issues. Maximize non-opioid options. You need to make sure that you've created and reviewing regularly their opioid treatment agreement. We don't use the word contract because we don't believe it's really a contract that you've agreed to give something to the patient, but it's an agreement between you and the patient, or an informed consent type of document. And if you do detect that they do have a substance use disorder, that you refer for treatment that particularly most likely will use medication-assisted therapy. We feel it's valuable to ask the SBIRT questions at every visit to screen for the substance use disorder mental illnesses. We can give more information on that in a minute. Again, checking the PMP for multiple prescribers or co-prescribing of other sedating or addicting substances. Ask the patients how they take their opioids to detect diversion or misuse. I actually had a patient, an elderly lady that you wouldn't suspect was actually giving some of her opioids to her children, adult children, who had intermittent chronic pain, and we had to deal with that particular issue because she was inappropriately giving those medications to relatives. That you perform urine drug screens on them randomly and on a regular basis. And that you remember that tolerance, dependence, withdrawal, and opioid use disorder may occur in any patient. Doctors, lawyers, preachers, not just those that you think of as druggies, and those people that seem to have more issues, you would think. So what if you're wanting to taper patients and when to do that? If they've had no reduction in what we call our PEG score, and that is a score that if you haven't been using it, is a nice one to use as a monitor for the effectiveness of pain therapy. And PEG is an acronym for pain measure, enjoyment of life measure, and general activity measure. Kind of works more towards the functional aspect of pain therapy. If they have significant opioid related side effects, if their dose is over 50 MMEs per day, if they have significant medical comorbidities or mental health comorbidities, and obviously if they're using concurrent or co-prescribing of benzos or other sedative hypnotic drugs. Dose reductions, as we show on the table or on the graphic at the right, are only recommendations. We in our state, and I think around the nation, got into a tizzy of trying to take everyone immediately off of opioids when we came down with all these new guidelines and the laws in our state. And I truly know from talking with the director of the licensure board, Lyle Kelsey, and others, that they're not looking for getting people who may, even if they're over 50 MMEs per day, over 90 MMEs per day, that you get them down below that immediately. The goal is to document and to assess and to watch for side effects, both for keeping them on a dose, but also reducing the dose. Many patients got into significant health risk by reducing medicine too quickly, or even if you did reduce and the patient had a recurrence of pain or thought that they could take the pain medicine back at the same dose, then they got into an accidental overdose situation. And in those situations, that's the reason that if you're going to taper opioids, particularly in high dose patients, legacy patients, you would want to make sure that they had naloxone available and their family knows how to use it. But this graphic shows is that you discuss or listen to the patient, acknowledge their fears, set goals, life goals, ask about needed support they may need, educate them about the other non-opioid therapies. And that if you're going to taper, slowly taper, reduce dose by no more than 5, at most 20% per month. Some patients can go more quickly, some can't, particularly those that have been on longer term opioid therapies. And assess by evaluating their function and pain control and monitor for withdrawal symptoms. This graphic shows that we want to support our patients through the taper process, talking about balancing the concerns over the benefits. Recommend, again, naloxone to prevent opioid overdose deaths, particularly in those areas mentioned. And I think this one graphic in the middle bottom part, it takes as little as 1 week to lose tolerance, and opioid dose reductions, voluntary or involuntary, will put patients at increased risk of overdose deaths. We do have a graphic on the right showing the commonly available types of naloxone. The Narcan nasal spray, 4 milligrams, is probably the one most commonly available. And we can get that to patients now through a variety of means that free of charge through naloxone hubs that Missy will go over with you, that you can give out to patients. We think it's wise to keep that on hand to keep themselves, their family, and their friends safe. And it, at this point, does not require a prescription and is available in a variety of ways, as I mentioned. If you do detect substance use disorder, which is a chronic, relapsing, and treatable condition, and where that becomes an issue is the repeated use of substances of any type, whether prescribed, legal, or illegal, that does cause a neurochemical change in the brain. And this does usually, in most cases, require treatment to overcome. And the DSM-5 criteria is listed here. You have to have at least 2 of those criteria over the past 12 months to meet that, but that doesn't mean necessarily that you can't begin treatment in certain situations. And SUD can be managed with effective treatments. The one that's most popular is Suboxone, but you can also use methadone and Vivitrol in certain situations. On the Vivitrol, you have to make sure the patient's been off an opioid for a period of time before you start that particular therapy. But using those therapies does show, or has been found to increase retention in treatment, reduce the risk of overdose, and decrease recurrent substance use disorder. Again, using the SBIRT technique, you can identify patients with substance use disorder. We think that the use of the SBIRT screening tool method is the best way to do that, asking all patients about substance use disorder using the audit and DAST tools, and assess for those who screen positive. If they are a low-level user, then doing a brief intervention is probably the best way to handle that. If you do detect a more severe case, then referring or initiating treatment for those with substance use disorder would be very appropriate. We do have a toolkit available for you. Again, this is a program that's that we have available. Our other resources that are available is through SAMHSA and our Department of Mental Health. We do also participate with a variety of practices around the state in our original program called Do No Harm. That's for those that have practices that don't take care of a lot of the older adults. This is a references that are available if you want to read up on those, and those are available to you on the handout that Missy will give you. We also, part of our program is we want to, as part of the Rise OK, is to do a practice self-assessment and look at the quality of care in this particular area for each of you, your financial security, joy in practice, and community engagement. We do this for all of our projects through the Oklahoma Primary Healthcare Improvement Cooperative. And we ask that you code your particular level of where you are now, such as you're using this particular protocol all the time, which would be a 5, to not using it at all at this time, which would be a 1. No answers incorrect or wrong. It's just that you are where you feel that you're doing in your particular practice. And then you go through and prioritize what you want a practice facilitator to assist you with. And we want to have you choose the top 3 to 4. You don't have to choose every one of these, but we are looking for safer opioid prescribing, particularly, and better in age-tailored pain plan. So I would ask that you think about choosing at least one of those in those areas, but also look at better mental health and look at the other issues of financial security, joy in practice, and healthy community. And with that, our other practice medical director and our principal investigator in this project is Dr. Lee Jennings. Lee is, if you don't know, she's the head of geriatrics at OU Oklahoma City. She works with me and Dr. Zolt Naga Kaldi in this particular project, along with Dr. Lee Jennings. We also have Marty Jelly that you all obviously know, who works with us on a variety of other projects. All right. With that, I'm going to stop. Hopefully I didn't bore you to tears. I'm going to stop my share and ask if there's any questions. Ryan, anything? I know that some of this is very common. You all in your internal medicine clinic, I know we're kind of at the forefront many times of treatment of pain and that type of thing. And so hopefully this won't be all of a new stuff to y'all.
So relatively speaking, we were at the forefront. We were not on the good side of it though, at one time, in my opinion. We made a lot of changes a few years ago because
Okay.
we had a lot of patients. We had a lot of patients who were coming in who were really inappropriate, acted inappropriate. We were overwhelmed with pain and addiction, and we made the decision to address that. And I think we have. My question is really a couple of things. One is when we have tried to avoid prescribing opioids, and we have tried to avoid being the prescriber for chronic opioids. We have a lot of patients that come in already taking them, no desire to stop. And so we're for them to remain our patient, we're kind of stuck.
Yeah.
We don't want to prescribe it. They say they need it. They don't want to get off of it. So we end up sending them to pain management. And I'm using that very generically.
Sure.
Because that's whoever it is. And they end up with all kinds of craziness. I mean, all things happen, and I just wonder if you could give us any advice on that, Brian, I may be wrong, but I don't think we've really identified anybody in Tulsa who I would say is our go-to person who we think is going to follow the guidelines that we expect. They may be legal, but that's it. So I wonder if you could give us any advice on that.
Well, I too have been in those situations, Mike. I have patients that are what we call the legacy patients that have been on chronic opioids prior to the advent of many of the guidelines and the laws that our state put into place. And I have consulted pain management. Most of those are the, anesthesiologist and, interventional type of pain management where they're not interested in managing the chronic pain patient. And I've found that following these guidelines helps me in dealing with those patients, even though I've not been able to reduce. I have several patients that I've not been able to reduce a lot. I have reduced their dosing, and I feel more comfortable caring for these patients if I follow the guidelines. I don't, if you fire them from your practice because they're on opioids, that doesn't seem like the right thing to do. And you work with them over time. I've had some patients get off of it totally. I've had most patients who've stayed on it, but at a lower dose with advice and counsel, and using other modalities. I've had them consult with the interventional pain management to make sure that we're addressing all of their options and documenting those options so that they're aware of what they can do. I did have one patient that I wasn't managing their opioids. Interestingly, a psychiatrist who had chronic pain management background was managing it, but she kept having problems with falls. And she was had multiple problems. She had gone through a renal transplant. She had had breast cancer. It wasn't metastatic, but and also was depressed. But she lived much longer than all of her siblings had lived because they all had polycystic kidney disease. And I felt actually, even though she ended up passing away, she didn't pass away from the opioid issue. We kept that as an issue, though she did suffer quite a bit from repeated falls and fractures. But we we tried to reduce those dosages, but we looked, she and her husband came in on a regular basis. She was nowhere near a, what you would classically think of as a drug abuser, but we looked at her almost like a long-term hospice patient and did as best we could to make her life as successful as possible. And I looked at the goal, and I never felt uncomfortable, even though I wasn't the prescriber of her opioids. She was getting treatment for her depression. She was getting treatment for her other medical situations. And I tried to coordinate that the best I could. And we made sure she had naloxone available, and her husband had that. And they all understood the issues associated with it. And in the end, it to me was a successful treatment, even though she was on long-term, relatively high opioid dosing. And so I don't see that as a failure. And I think that's where we got into the mindset that if we don't get people off of opioids, it's a failure. What we look at is goals, and we try to document those in the chart. The issue with her, she did have repeated falls, and I believe she was having issues with the opioids, but she obviously couldn't tolerate many other because of a renal transplant, and other modalities weren't effective for her. I don't know if that helps.
Ryan, what do you think? I mean, you're seeing a lot more of these patients than I am.
Well, I was going to say my comment on in terms of our practice, because I wasn't necessarily around when all those changes occurred with our faculty and our resident practice, but I will say, I think when I look at my own panel of patients, things that as a clinic that we could probably revisit and improve upon nowadays is, especially as it's been a few years since that change was made, that policy was put in place. We've had new faculty, myself included, come on board. And there was this point where, we might need to revisit our procedures, or make sure that at least we're at the standard of care in terms of caring for our patients on chronic pain medications. And that includes, making sure that if they're above the 50 morphine mill equivalents, they have naloxone on hand.
Yep.
That we have pain agreements on hand, that we're at least doing it in a safe way. And so that to me is, to be honest with you, from the resident clinic and any new patient I have that I think is going to be somebody who's going to need chronic pain medication to have functioning in life, usually I try to get them involved with one of these pain management physicians. And like Dr. Weiss said, we don't really have necessarily a go-to clinic for that. We tend to change clinics at different points, and we've actually had to cut off referrals to certain clinics too as well that we thought were inappropriately managing those patients. So it's a constant game of making sure we're doing the best for our patients, making sure we have some sort of a standardized procedure, especially as we have, newer faculty come in. We're looking to hire multiple people coming in. We want to make sure, especially some of our own residents who might not have as much experience with prescribing these kind of medications, and that's really an area I think we could focus on, improve on in our clinic, our practice, especially.
I would agree.
Because I'll be honest with you, I've inherited a lot of patients over the past year who are on medications like this, and I tend to, a lot of them have been on it chronically on a stable dose, and I have those discussions with them about tapering or seeing how they do, and most of them are willing to do that, or they just, they've been doing fine on it. But a lot of the topics you discussed with screenings and things like that, I'll be honest with you, it's not done routinely. So, I think that's something that I know my own panel of patients could be improved on.
Yeah, it's difficult to do if you don't have a kind of a routine process like you do right now. Probably every patient that comes into the clinic gets weighed and has a blood pressure checked at a minimum, probably their pulse, and they get a pulse ox now too. And they're asked about COVID symptoms. and if you get into place, doing a routine expert screening tool, you have somewhere or another that you put a reminder that you need to go over the pain management checklist that you can put into place. That can be very helpful to me. That's what I found very helpful. And I put a reminder in the centricity that I think you all are still using. I actually put up pop-ups in there as a reminder when I need to do those on a regular basis, such as redoing the pain management agreement, such as when at least I want to do an annual urine drug screen. If they are seeing other consultants such as psychiatry or others, that I put a reminder of when they need to be seen for that. And when their earliest refills for medicines are up. We do have the forms for the PMP that you can check, make it easy to check into. That's very helpful for me, that I've used on a regular basis.
Yeah, and one thing we actually did recently was review the pain policy that was put in place with Dr. Beasley when a lot of these changes occurred. And we actually did change some things because, we were also trying to balance a burden on patients too. One thing that was initially done, and I think rightfully so at the beginning, was we had, especially as all these changes were occurring in the clinic, was patients needed to have monthly nurse visits for prescriptions and things like that. And we realized that might be an unnecessary burden, especially for a lot of our patients during the pandemic. And then also with transportation difficulties and things like that. So,
and now that we're doing all electronic prescribing for almost everything, including particularly scheduled drugs, the need to come in to see a nurse or somebody becomes less critical, as it were, but there's still the need, interestingly, to put this, we've changed the name in my clinic at Family Medicine in Oklahoma City. Instead of calling it a pain management clinic, we call it a COAT, C-O-A-T, chronic opioid analgesic therapy. So it doesn't have the ring of a pain. This is a pain patient. We call it a COAT visit. just sometimes words make a difference, and the issue of how you label and how even your front staff look at patients. They may, this is one of those, druggy patients. I think it's important to note that, even if they are on chronic opioids, they deserve the same respect that all your patients do. And that's why we changed the terminology for that, call it COAT rather than chronic pain.
Yeah, I agree. I think, it's one of those things where, opioids may be necessary at times, to help people. Right. But creating something where we can limit everything's a diversion and misuse and everything as much as possible.
Definitely. I think those are very critical to be involved with, and when you do detect that, the other interesting term that's in the literature is that when patients are, say they come in and their urine drug screens positive for a substance that isn't appropriate, or they aren't following the pain management agreement that you all have put into place, you don't necessarily just fire them right away. Unless, again, there are in situations that you would, if they come in and their urine drug screens positive for a substance that isn't appropriate, or they aren't following the pain management agreement that you all have put into place. You don't necessarily just fire them right away, unless, again, there are in situations that you would, if they come in and their urine drug screens positive for a substance that isn't appropriate, or they aren't following the pain management agreement that you all have put into place. You don't necessarily just fire them right away, unless, again, there are in situations that you would, dismiss a patient immediately, if they're threatening to your staff or your other personnel or other patients. But if you, what they call guideline non-coherent or non-compliant, or, is what the word that I see in the literature, guideline non-compliant, that they're not following the guideline, and therefore you attempt to get them back into the guidelines of what they should be doing, because patients do have incidences of, they're human and they don't always follow the strict guidelines that we think they should be following. And they may honestly, I've had patients that, didn't know that they had forgotten that they needed to notify me after they went to the dentist and got some, opioids for their dental extraction, or they went to the ER for an acute injury. So those types of things do happen at times, and guideline non-adherent, as it were, is what I call it, and what the literature calls it.
I will say I think this talk is given to the residents too as well during an academic afternoon. And I think it'll be good information. I will say, coming out of residency, I wasn't as attuned to like proper guidelines, things like that, and opioid prescribing, just because we didn't do it often in the resident clinic.
Right.
That's another area I think that would be helpful, especially in the training, because a lot of our residents, they go out and they are in practices that have a lot of opioids being prescribed. So knowing how to do it safely too, as well as
you may want to consider for your resident practice, what we did in family medicine is that they would have to go through a variety of training, and they could then become essentially qualified by, if they did, there's some online or board associated training. We have an online CME, that they could take, but for what we did in our residency, they had to have gone when they weren't a first year. The second is that they had to go through the American Board of Family Medicine Pain and Opioid Management Program, CK program, and then they would have to get, they would get limited types of patients, not if we actually graded the patient based upon their risk level. If they're over, 50 MME per day, they were, or had combination therapy, or they had significant behavioral health issues, they were, a grade 3 type of patient. If they're grade 1 or 2, then we would consider them to be a resident appropriate. Uh-oh. Is that okay? I hear some background noise there going on. Anyway, it went away. So we would actually allow our residents in a limited sense to start prescribing, so they got some experience during their residency under supervision, but they had to follow certain criteria to get to that point. It's not that they necessarily desired to do that a lot, but we had them all go through the training that the board has available, and we also had them do and graded the patients, as it were. So if they met certain criteria, then we actually tried not to take care of many of those patients that had the very severe issues, if they already had a substance use disorder or something like that. I do know that many res programs, I shouldn't say many, I know Minnesota and the state of Washington have worked at getting their residents comfortable with prescribing drugs like Suboxone, and doing substance use treatment, because that seemed to help encourage them when they went out into practice, because we certainly need more primary care clinicians doing substance use disorder treatments. There's just a great need out there for that, as you probably have experienced, it sounds like. And so it may be worth looking at, and how other residency programs have instituted that particular training modality in their residencies. All right. Well, Ryan, I think it looks like people are dropping off and needing to get to other things. I think Missy needed to do some consenting of a few of you all, from what I understand, right, Missy?
Yes, if there's enough time, I don't know if others can stay on for a couple of minutes, and if not, then I'll work with Dr. Yarnell to figure that out. Thank you, Dr. Crawford.
Well, thank